Good morning and warm welcome to Online Anaesthesia, postgraduate teaching program and Zoom platform sponsored by Akrula and hosted by Anaesthesiologists and simultaneously aired by Anaesthesia TV. Today we are having two interesting topics in pediatric anesthesia, that is pediatric pain management and perioperative fluid management in pediatrics. For that, we have two eminent speakers in our online anesthesia platform, Dr. SANJAY PRABHU and Dr. R. JAYANTHI. I welcome both to online anesthesia platform. Today's session will be coordinated by Dr. RAJESH JEYAPRAKASH sir. Over to you, sir.
Good morning, one and all. Thank you, sir. Good morning, one and all. First of all, I would like to thank both of our speakers because they are spending their valuable time along with us for these two sessions. And this is going to be a very useful session for both MD and DND postgraduates. The first session is about pediatric pain management, and it will be done by Dr. SANJAY PRABHU. I think he is the ideal man to talk about the pediatric pain management because in 2015, when I was hearing his lecture in ISSP Con, he was talking about DNC and the pain for the fetus. So such a forward-thinking man over the pain about the pediatric pain management. And he had done a special fellowship for that pain medicine from Australia. And right now he is the secretary for Tamil Nadu State Branch of Indian Association of Pediatric Anesthesia. So we welcome you, sir, Dr. SANJAY PRABHU, sir, for your talk.
Let me share my screen.
Yes, sir.
Can you see my screen?
Yes, sir, we can.
Yes, sir.
Hi, good morning, everyone. Thanks to Dr. Edward and Dr. Rajesh. Thanks, Rajesh, for that elaborate and wonderful introduction. So, it's good for me to be talking on a Sunday, and I'm even more impressed that a lot of postgraduates can dedicate their time and other practicing anesthetists to be available on a Sunday, because Sunday, I think all of us, I think it's a very crucial day for us. We have a rest day, but to have this program running on a Sunday and to do it successfully for almost 38 sessions is very impressive. So hats off to Rajesh, Dr. Edward, and their team for all the effort they've put in to get this program going. Right, so I work at Apollo Children's Hospital, and I've been doing exclusive pediatric anesthesia. I've been doing exclusive pediatric anesthesia for the past 9 years now. And this topic, thanks Rajesh for giving this topic to me, because it's something which is very very passionate for me, and I take this topic, this particular topic in pediatrics quite seriously. It's an interesting topic, but it's quite a distressing symptom. So as we all know, that pain is probably the commonest symptom why someone comes to a doctor. And it's even more interesting that in children, I think the most important fear when they come to hospitals is about having some kind of a pain, starting off with a vaccine or an injection or an IV cannula. And for them to go through something like an operation, it's a massive stress for them. So we as anesthetists, I think we can make that journey as comfortable as possible in the perioperative period. So overview of what I'll be covering is a little bit of anatomy of pain, pain assessment, sensitization principles, general principles of pain management, both pharmacological and non-pharmacological. So I'm just running through certain points which is commonly misconceptualized. So one is, so I just want each of you to think within yourselves for each one whether you think the statement is true or false. So a 3-week old child can feel more pain than a 3-month-old child. So is that true or false? I'll leave the answer to you, but you will get the answers as I go through my lecture. I'll just change my view for a minute. Okay, so paracetamol is best given as a suppository in children because its absorption is good as in good as the oral or the IV route. Fentanyl patch can be given for postoperative pain if the expected pain is supposedly quite severe. Again, I will leave it to you whether it's going to be true or false. When you have someone having an infusion of opioids, either in the intravenous route or in the epidural route, how do you pick up a respiratory depression? This is the earliest sign, a decrease in the respiratory rate. A child with intellectual disability or cognitive impairment could experience more pain in the perioperative period. Neuropathic pain occurs commonly in adult patients after certain kinds of surgery. What is the same concept with children? Are they more likely or less likely to feel pain? Ibuprofen provides good analgesia for all orthopedic procedures in children. Nocebo-hyperalgesia is a phenomenon which has been demonstrated in children. So coming to the topic per se, so how is pain different in children? So it's been clearly shown that newborn and even premature children can perceive pain. And as Rajesh had pointed out earlier when he was introducing me, that even a fetus in utero can perceive pain starting from 20 weeks of gestational age, because the nervous system is fully mature by that time. And second is interesting is, younger the child, they have a lower pain threshold. The reasons we will go through. And the emotional distress a child can go through when they perceive pain is much higher, because of which that coping mechanisms can be different. Pain assessment in children, particularly in the non-verbal age group or in children who have intellectual impairment, they can be quite challenging. And finally, I think we need to give a lot of credentials to the parents or the caregivers when it comes to managing pain in small children. So all of us know about this basic anatomy. So when we have some kind of a stimulus, it runs through the sensory fibers, it goes to the spinal cord, and from there it goes to the thalamus, and finally to the sensory cortex before we appreciate the intensity and the location of pain. Now, the same diagram, now the red one is the ascending pathways. So whenever we feel some kind of pain, we immediately perceive the pain within a few seconds. But what happens simultaneously when we start feeling the pain? There are some inhibitory pathways from the brain to the spinal cord, which tends to modulate the pain we perceive. So after a certain point in time, the body tries to have some mechanisms to decrease the amount of pain we perceive by certain descending pathways. And the main chemicals which are involved in this are the norepinephrine and serotonin. Now, this pathway, the descending inhibitory pain pathway, is not well developed in small children. So that's one reason why they have a higher pain perception or a lower pain threshold. And smaller the child, they are more likely to experience more pain given the same amount of noxious stimuli. Okay, so if you have a 2-week-old child having circumcision and a 2-year-old child having circumcision by the same surgeon, the 2-week-old child is likely to feel more pain because of this particular reason. And one more point is they have a what is called a wind up. Wind up is basically a phenomenon where even fibers which normally don't carry pain can carry pain, and the spinal modulation of pain is more intense in these patients. So one common thing which has been studied across pediatric literature is any child who spent some time in the ICU. See, quite often we have patients coming for surgery sort of 3 years or 10 years down the line for a simple procedure. But it's important to ask for a history of NICU admission. So during the NICU admission, they are subjected to multiple painful procedures. So at this small age, when they have multiple painful procedures, even things like venipuncture, what happens is it sensitizes the child to pain, and there seems to be some long-lasting changes in the anatomical pathways and the physiological mechanisms, which makes this child more susceptible to pain later on in the future for whatever painful procedure they come in. again, so one of the points is this point is also applied to adult patients. So the pain tolerance or the pain threshold, how much pain a patient can tolerate, tends to vary significantly among different age groups, and the mechanisms can be quite different. It starts off from things like genetics and pain, and how they respond to a particular drug. Paracetamol might be a good pain medicine for one child. It may not work well for another child. Likewise, a diclofenac might be good for one child, but it may not work for other child. This is something to do with genetics and pain. Apart from that, other factors as well: previous painful experiences, history of chronic pain, anxiety levels of the patient. All these can make a significant impact on how much pain a particular patient perceives. So when you see a child or a patient before anesthesia, how do you know that this child is more likely to perceive pain, or you need to be more aggressive in this patient when it comes to pain management? It's not always possible to judge it, but there are certain cues we can get from the history and the examination. So if a child has been subjected to previous painful procedures, or if the child has had an unpleasant experience in the past when it comes to poor pain management, which you can elicit from the parents, again, it makes them more susceptible to pain in the present surgery. Any anxious child or anxious parent can lead to higher distress from the painful procedure. History of chronic pain. So we have some children coming with history of chronic abdominal pain. I mean, two most common chronic pain conditions seen in children is one is a headache, and second is abdominal pain. So if a child with a previous history of recurrent headaches or recurrent abdominal pain comes for an acute intervention, like let's say for a circumcision or for a tonsillectomy, the amount of pain medicines they will require, or the amount of pain they perceive during that operation, is going to be much higher compared to someone who does not have chronic pain. And finally, something I mentioned earlier is about the pain genes. Some genes make them more susceptible to pain perception. And yeah, children with cognitive impairment, children with autism spectrum disorders, these patients, they experience the same amount of pain as the normal patients. However, the pain assessment can be challenging. So that's where we have the difficulty in treating this pain. So because of which there might be an under treatment of pain in these patients. Yeah, so as I mentioned earlier, since the pain threshold and pain tolerance tends to vary across individuals, you cannot have the same prescription for 10 children. Okay, so you need to sort of judge the patient based on the past medical history, how severe the surgical intervention is, and you might have to keep following the patient up in the post-operative period to see how the medications you have given works for the patient. So you need to keep, it needs to be individualized approach to the pain management. So just a question for the postgrad is, so among the four age groups, pain sensitivity or the pain, which age group has got the highest pain sensitivity or more likely to feel pain? So based on what I've lectured so far, it's clear that preterm has got the highest sensitivity to pain. So because of the abnormal descending inhibitory pathways of pain. One other point about newborn patients perceiving pain is even a non-noxious stimuli can cause pain in these people. So for someone who has visited the NICU, if you've seen a small child lying in the NICU, even when you make a sound or touch the patient, they will have some kind of withdrawal response. Okay, you could call that a kind of allodynia or a non-noxious stimuli causing an exaggerated response to pain. Okay, and one of the points is fibers which normally end up in lamina 1 and 2. I mean, the touch fibers can connect with the pain fibers in the spinal cord rex lamina. So, which means even non-noxious stimuli can be perceived as painful stimuli. So the question comes is, why do we need to treat pain? Are there any sort of consequences? Some people say that it's a common concept among some physicians that no one can die from pain, but they can die from a morphine overdose or an opioid overdose. It's partly correct, but can pain can painkiller patient? Maybe yes, because of the consequences of what happens in various systems. So there are a lot of features of acute pain consequences wise. Again, it's a big list which is seen in all the books. But there is increased release of some catecholamines, which can make you more susceptible to even a cardiac event, particularly in adult patients. So, but leaving out the acute effects, apart from what we've seen here, there are things like lowering of the pain threshold. That's one. Second is distress, emotional distress to the patient. Third is lack of sleep, distress to the parents. So all these can make the overall outcome to the child quite significant. Apart from the acute effects, there are some chronic effects of pain which is not treated adequately in the post-operative period. One is called the CPSP, which is the chronic post-surgical pain, and there seems to be a long-term or a long-lasting reduction in the pain threshold. So this is quite significant, and this happens particularly more likely in a smaller child. So you need to be more aggressive with children with treating pain, particularly in the very small age group. Yeah, so this was evidenced by a few studies which mentioned that when you do a circumcision without proper pain relief, subsequently when the patient comes for vaccination, the amount of pain perceived during the vaccination is higher in someone who's not had a proper anesthesia during the circumcision. Okay, likewise, as I mentioned earlier, children who have spent time in the NICU, they seem to have a lower pain threshold for all procedures subsequently later on in the life. So at present, we have a patient in the hospital having repeated defilements for a facial burn. So would you expect that this patient will have a higher pain sensitivity or a higher pain perception compared to someone who's coming surgery for the first time? It's a definite yes. This is where we have what is called the sensitization theory of pain. So as shown in this diagram, so we have the stimulus intensity on the x-axis and the pain intensity on the y-axis. So with repeated surgeries, what happens is with a lesser stimulus, the patient perceives more pain. That is what is called as hyperanesthesia. Okay, so a painful stimuli which will normally cause a pain score of 2 for one patient will cause a pain score of 8 for another patient. This is because of the phenomenon called peripheral sensitization. And we have this, if you look at this picture in the diagram, so when there is increased pain perception at the site of, at the wound site, it's called primary hyperanesthesia. And what happens subsequently if the pain is not treated adequately, the field from where the pain is perceived tends to increase. So the subsequent, the wound or the area around the wound will also become hypersensitive, and that is called what is called a secondary hyperanesthesia. And we also have this phenomenon where non-painful stimuli can cause pain, which is called allodynia. And some people have the pain which lasts much longer than the actual stimuli, which is called aftersensation. So all these happens when someone is not treated adequately for pain, or when they come for recurrent procedures. You can see all these. You can see allodynia, you can see hyperanesthesia, you can have aftersensation, or they could have pain without any stimuli at all, which is spontaneous pain. Okay, so here are two concepts which I'm trying to explain in this slide. So if you look at this diagram in diagram A, so you have the duration of surgery in green there. Okay, the hypersensitivity, the neural firing tends to start from the time the surgeon puts the incision. Okay, it continues through the perioperative period. Okay. Now, when you give some kind of anesthesia before the surgery starts, so if you do a block before the surgery starts, the amount of hypersensitivity is significantly reduced. Having said that, the duration of block which you give, let's say it works only for 6 hours. What happens after 6 hours? The pain, once the block starts wearing off, the patient starts feeling pain, and which may not be adequately controlled by parenteral pain relief. So again, the hypersensitivity starts. Okay, so when you want to achieve good perioperative pain relief, you need to dullen this hypersensitivity. So this concept of pre-surgical anesthesia is earlier called the preemptive analgesia. Okay. Now, what the new terminology is called preventive analgesia, where they're trying to minimize the hypersensitivity through the perioperative period till the time of wound healing. So they make sure that when you have a patient coming for a laparotomy, you do an epidural infusion, which can provide pain relief for a good 3 or 4 days. Okay, that is called preventive analgesia. Preventive analgesia is giving pain relief, adequate pain relief for the entire duration of the perioperative period, right from during the operation and after the operation. So all of us know about this classification. We know nociceptive pain and neuropathic pain. So nociceptive pain is pain from muscle injury, nerve injury, muscle injury, and tissue injury, bone injury. Neuropathic pain is pain due to nerve damage. Okay, so with these two terminologies we are familiar about. But there is one more terminology called nociplastic pain. Okay, nociplastic pain. This is a pain which is it's not a localized pain, but it's more common again in children who've had chronic pain, or adults who have had chronic pain coming for an acute painful procedure. So they have exaggerated pain perception, and they can complain pain at multiple parts of the body, though the pain source is only from one particular site. Okay, so nociplastic pain is more seen in patients with pre-existing chronic pain, or patients who've had multiple painful procedures coming for a subsequent painful procedure. So with nociplastic pain, you have the other effects of pain, which includes behavioral disorders. They have abnormal, so they could have increased levels of anxiety. They could have mood changes like depression. Sleep can be deprived. So all these come under nociplastic pain. So assessment of pain can be challenging because they are non-verbal, and some may not have the cognitive ability to say pain. So a lot of children, what they do is they can tell you whether they have pain, yes or no, but they cannot tell you the severity of pain. So that can be a challenge. So it's good to sort of get the parents' opinion when it comes to pain assessment in children. Third thing is, so you don't look only at the pain score. When you look at pain assessment, you need to look at the pain score as well as the effects of the pain on the patient, whether the child is behaving normally, the child is eating normally, drinking normally, sleeping well, the child moving about. So you look at other aspects apart from the pain, which is multidimensional. And finally, you need to look at what is called the dynamic pain score. So when you go and see a child in the postoperative period, at rest, what you say is the pain score. Okay, so a child post laparotomy, when the child is breathing normally, you ask for a pain score. It's 3. You ask the patient to take a deep breath and ask for the pain score. So with movement, the pain score should be comfortable. Okay, so a dynamic pain score is something which has to be elicited with movement, and if the child is still comfortable with the movement, then it means your pain control is adequate. Okay, this particularly applies in situations where you need to have physiotherapy. So if you want a chest physiotherapy for a patient post-thoracotomy, post-laparotomy, or limb physiotherapy for someone who's had a knee surgery. So in all these situations, you look at the dynamic pain score as well, apart from the static pain score. Okay, so I think I mentioned this one. So these are the various pain scores. I don't think I'll go through them. NIP is the neonatal infant pain score. FLAX score is used in less than 5 years. FACES score 5 to 9 years, and the numerical rating scale is more than 8 years. Generally, we're trying to achieve a pain score less than 4. So that's a child, a neonate having a pain. It's not easy to judge pain, but clearly, if you see this child, it's crying, eyes are closed, and the patient is having sort of an opistotonic posture. So this is commonly seen in neonates having pain. So this child did not have a regional block for the circumcision. So I just play the video. So this particular posture, opistotonic posture, is usually indicates pain in this patient. Okay. Now, from the FLAX score, they have made a small change, which is called the revised FLAX score. So the revised is basically, if you look at the letters in italics, so this is available on the online, so you can go through it. So this is used for patients with cognitive impairment. And here we take the opinion of the parents for each component of the pain score. So that's where it becomes revised. So in the letters in italics, basically, it has to be looked at, and you get for each, for face, you need to get the parent's opinion. Likewise, legs, for each component, you need to get the parent's opinion to confirm what you have assessed. So that's the revised FLAC score, which is recommended nowadays. Faces score. Pain management, so what are the strategies? We have the pharmacological, physical, psychological, and the vaginal techniques. So when it comes to goals about what you're trying, the pain, adequate pain management, one is assess the pain score. Second is there are certain aspects which can cause significant distress to a child. So pain may not be the only one. So even things like having a parent along with a child, okay, or things like giving medications for a child, the pain from the IV side, all these have to be taken into account. Third thing is try not to target only the pain score. You need to look at what the child can do. The functional recovery is important. So whether the child is playing, eating, drinking adequately, sleeping well, all these have to be addressed apart from just treating the pain. And finally, multimodal anesthesia. So general principle of pharmacotherapy is you aim for multimodal anesthesia, which is basically trying to give more than one mechanism of drugs with different mechanisms of action. Second is try and always have two kinds of prescriptions. One is some regular pain relief, and if that doesn't work, you need to write something else which will help in case for the child is, let's say child is having a physiotherapy and the pain relief is not adequate. You need to have something to cover the physiotherapy, which is breakthrough pain. And finally, the age-appropriate pain relief. Particularly when most of the surgeries which we do is with the daycare surgeries, but there could be some surgeries where the patients are admitted. So just make it a point to go and see them in the postoperative period. You will learn a lot of things as to how your pain prescriptions are working. And generally, surgeons are very depend on you for pain relief. So and they would really appreciate if you could take care of the pain relief in the postoperative period. So a 3-year-old child post-hypospadias repair is not responding to IV medication. So how do you deal with this? So this is a child which every time the nurses go and approach the child starts screaming. So this, on further sort of discussion, we found that the IV site was causing a lot of pain. So once we changed the IV, the child is sort of settled down. So it's not only the operative site you need to look at. There are other aspects which a child can be distressed about. Typically, a child having IV for a long time, that could cause a lot of pain. So just make sure that that is addressed when you see the child. So, so this is suppose is something which is very commonly used in the children. Having said that, they don't have a very predictable absorption. Okay, like for example, paracetamol supposedly is commonly used, but it's got a very unpredictable absorption, and it takes a long time to work. So, given a choice, oral routes are better than suppositories. We also have patches which can help. Particularly if a child is not willing to swallow, then patch can be considered. And one more thing about suppository is do not cut a suppository. Okay, so apparently the drug which when they make the suppository, it has got an unequal distribution. So by cutting a suppository into half, it doesn't necessarily mean that you're cutting the dose to half. Okay, so never cut a suppository and insert it. If it's a small child, if you're not able to use suppository, then change the route. Again, this is something which we routinely do in our hospital. So when a child is coming to surgery, how can you make it more comfortable by for the IV cannula? So important thing is don't think only about medicine. Okay, so when you have a child who's wanting an IV cannula, who's refusing IV cannula, one is you might want to try distraction therapy. Second is if you have a very supportive parent, you could have a parent with a child. And third is Embla cream. Okay, that's something which you could try. This has to be applied at least 40 minutes to an hour before you attempt the cannulation. to be effective. So among the drugs, I'm sure all of you know this, but just about the word about sucrose. So sucrose is used in very small children before a painful procedure. So what they say is we don't have sucrose in our country, so you could use 25% dextrose. You can give small sips of 0.5 to 1 ml, which is given 1 minute before the actual intervention. So even things like phlebotomy, you could attempt giving dextrose and trying the phlebotomy a minute after the sucrose. I'm sure all of you know about the pain ladder. So depending on the severity of pain, we tend to sort of change the drugs, starting off with paracetamol, NSAID, add tramadol, add opioids, and finally think of adjuvants at all stages. Coming to paracetamol, which is the commonest drug which we use, it's a safe drug, very minimal side effects. IV is the best route if you have an option, followed by the per oral route, and then lastly the per rectal route. Again, the normal dose is usually 15 to 20 milligrams per kg, but in children less than 3 months of age, the IV dose is only 7.5 milligrams per kg because the metabolic systems are saturated, so they may not be able to metabolize if you give too much of IV. One thing about paracetamol you have to remember is it's one of the commonest drugs involved in dosing errors across the world because it's available as a combination with other medicines like diclofenac or ibuprofen. So quite often I find junior residents writing prescriptions. They will write syrup comiflam. They will also write syrup paracetamol, not knowing that both has paracetamol. So so the risk of hepatotoxicity becomes quite high when you use paracetamol, particularly when you exceed the dosage. And this risk is higher when you have a child who is dehydrated, malnourished, or who takes other medications which can act on the liver. So again, that's different age groups with different dosing. And if you look at very small children, okay, the oral dosage is the maximum dose is only 30 milligrams per kg per day. And above 66 months, it's 90 milligrams per kg per day. Intravenous paracetamol, as I said earlier, small child, you stick with 7.5. And finally, once they are term, it becomes 15 milligrams per kg. Okay, NSAIDs, we try not to use for children less than 3 months of age. And above 6 months of age, it can be safely given. So whenever you're giving NSAIDs for a patient, make sure that they are adequately hydrated. Otherwise, you could risk renal injury. Apart from that, you have effects on they can have effects on the platelets. You could have colitis. And another common concept which I've found, particularly with non-anesthetists, is many people think that a diclofenac suppository or an IV diclofenac is safer than giving oral drugs. Across all routes, they irritate the stomach. They are gastroirritants. So just be aware of that issue. And there is no difference among the various NSAIDs in terms of efficacy or side effects. Having said that, we have this class of inhibitors called COX-2 inhibitors. So they do have some benefits. They seem to have less effects on the stomach and the platelets, though the nephrotoxic effects are still the same. So quite often we have a nurse coming from the PACU saying that this child has had a laparotomy. There's no epidural in place. Child is complaining of severe pain. So this tramadol is an option. So I personally would say tramadol is not a good medication for severe pain, but it can be given for moderate pain. And tramadol in combination with paracetamol and NSAIDs might work. But when someone is complaining of severe pain, I think the only drug of choice we have is opioids. But tramadol is very commonly used across the country because one is it's easily available. There is no restrictions in terms of drug usage. And it's got a dual mechanism of action. So this is the only drug which we use, one of the few drugs which we use in the perioperative period, which has got effects on neuropathic pain. Okay, paracetamol, NSAIDs, and MOPs and opioids do not have any effects on neuropathic pain, whereas tramadol tends to have some effects on neuropathic pain because it has got this mechanism where it tends to prevent uptake of norepinephrine and serotonin in the spinal cord. So that's one mechanism of action, and it's a a weak mu agonist. So that's why it's used for moderate pain, but severe pain, it may not help on its own. And compared to opioids, there seem to be less side effects in terms of constipation, pruritus, either similar or less nausea. And the opioid-induced ventilatory impairment. Yeah, opioid-induced ventilatory impairment is seen with opioids in certain patients. Again, this is less risk with tramadol. And it can be used as an infusion in this particular dose if you think you don't have access to opioids. There are some issues with tramadol. It tends to lower the seizure threshold. So in a patient with epilepsy, you have to be careful. It can trigger what is called the serotonin syndrome. And there are some pharmacogenomics effects where this enzyme, which metabolizes tramadol, it can be different in different individuals. So some people can have increased metabolite, or some people may not have much metabolite. So the effects could vary. So again, this concept of opioid-free was opioid-sparing anesthesia. I don't think it's possible to achieve opioid-free anesthesia in the absence of a regional, good working regional. But if you don't have a regional, you could try what is called an opioid-sparing, which basically means that you try and minimize the effects of opioids on the body. Okay, so among opioids, we have the commonly used morphine, fentanyl, and buprenorphine. But whenever you use opioids, you need to be aware of this particular issue, what is called opioid tolerance or opioid-induced hyperalgesia. This is particularly in children coming from ICU or NICU with opioid infusions on board. Yeah, these people generally will require a much higher opioid dosages intraoperatively. So you need to be careful about these individuals. So how do you treat these patients? If someone is having an opioid on board and they're coming to theater, one is either you can increase opioid dosages, or you might have to add these medications, either in the form of ketamine, alpha-2 agonist, or institute some kind of a block. Again, these are the various infusions which are commonly used. I think a lot of people who do pediatrics regularly will know about these dosages. Yeah, so morphine, generally the dose we use is 1 mg per kg in a 50 ml syringe at 1 ml per hour. Fentanyl 50 mics per kg in a 50 ml syringe at 1 ml per hour. In some patients, as I said, if they're not comfortable with this particular dosage, either you can double the dosage, or there have been recommendations where you can add ketamine 1 mg per kg along with morphine in the same syringe and give it, particularly in patients who have very refractory pain or pain which does not respond to the conventional dosages. Yeah, I think again this practice is being followed in a lot of places where the fentanyl patch is being used for acute pain. This is not recommended for a particular reason that the pain after operation tends to decrease with time. So the pain is quite severe in the first postoperative period, becomes less in the second, and becomes even less in the third postoperative period. Whereas a patch, it provides a stable pain relief. Okay, so you could risk respiratory depression if you're giving a fentanyl patch for a patient in the postoperative period. So you have to be more careful about giving this patch. So I personally wouldn't recommend, and a lot of societies don't recommend this particular practice of giving opioid patches for a postoperative pain control. For a cancer pain, yes, but not for acute pain. This is something which we use regularly in our hospital as an adjuvant in regional anesthesia techniques like caudal or peripheral nerve blocks. So we use 1 to 2 mics per kg of buprenorphine along with the local anesthetic, whichever choice you choose. Okay, there is a certain category of patients who have a high risk of opioid-induced ventilatory impairment. So this typically occurs in obese patients with sleep disordered breathing, patients with Down syndrome and cerebral palsy. So you just need to be careful about prescribing opioids in these individuals, or you need to have some kind of a monitor to look for respiratory depression. Now, so a common question I ask many postgraduates is, how do you recognize respiratory depression in a child or adult having opioid infusion, either in the epidural route or in the IV route? So they will be always drowsy or sleepy. So this then generally precedes the bed apnea, which we normally see. So if someone is always drowsy, unable to, not rousable on an opioid infusion, maybe it's a sign that they are going in for respiratory depression from opioids. So you need to stop opioids. Obviously, this is a very important point. Try and do a block wherever possible in children to minimize the effects of any parental pain relief. Okay, this is something which, again, we do this quite regularly in a hospital. So you have a patient who's coming for a major surgery, having a lot of pain in a postoperative period. So you give all these. You give paracetamol, NSAIDs, opioids, renals. Is there anything else you could add for these patients? So this is where we have the question of the analgesic adjuvant. So these are the various adjuvants which can be used in the perioperative period. So we have the alpha-2 agonist, nitrous oxide. I use nitrous oxide only in patients where I don't use a renal anesthesia technique, particularly when I think the pain is going to be quite severe. Apart from that, ketamine, again, it's a wonderful drug, particularly when it comes to anesthesia, where you think the child is going to have a lot of pain. So any patient where the pain anticipated is severe, you always have ketamine as one of the drugs which you use for pain relief. Apart from that, lignocaine has shown to be beneficial as an infusion in laparotomy patients. Dexamethasone, again, very useful in many patients, particularly proven in adenotonsillectomy surgery. And magnesium, yes, it's been used. Yeah, so I think the routine practice now is to give dexamethasone for all patients with coming for adenotonsillectomy because the pain relief is quite good. Okay, there are certain surgeries where the risk of neuropathic pain is quite high. So, and how do you recognize neuropathic pain? The patient will complain of burning sensations around the operative site and all these symptoms. They could have burning, tingling, increased sweating, and the temperature can vary. It can vary. They could say it's either hot or cold compared to the other side. Okay, so so all these might indicate that the child is having neuropathic pain, and the pain per se will have sort of a shooting character, or they could have things like allodynia or a hyperalgesia. So when you have neuropathic pain, it's worthwhile looking at these drugs, either gabapentin or pregabalin. And for major surgeries, I tend to give them as a routine in the pre and in the perioperative period. Again, this can be considered in certain surgeries, particularly in orthopedic surgeries involving the lower limb. They could have muscle spasms, so you could have things like diazepam or metocarbamol. Again, one of the points is a lot of patients who are anxious in the periodic period tend to perceive more pain. So when you have such a patient, you could consider sort of anti-anxiety medications, which will decrease the distress due to the pain they perceive. Okay, this is a website you can go through. It has got for each procedure they recommend what is the best pain relief. So it's called Prospect. Some non-pharmacological techniques which you should be thinking at is distraction, parental depression, anxiolytic techniques. So in very small children, we have this techniques called using a pacifier and breastfeeding. So what they generally do is you vaccinate while the child is being breastfed. That tends to have some kind of a distraction come analgesic effect. And the kangaroo care is basically skin-to-skin contact of the neonate with the mother or the father. Now, when it comes to communication, so again, I see some physicians saying when they're doing an IV cannula, saying this will not hurt. So that's a blatant lie, isn't it? You can't lie to a child. So when you do something with such a statement to a child and it hurts, basically you're losing confidence. So the child is not going to believe you hereafter. So never lie to a child. On the other hand, you can use words which will sort of say that you'll try and make it as comfortable, or you try and be gentle, and so on. Okay, so this is why we have the concept called nocebo. So we all know what is placebo. Placebo is benefit from a substance, whereas nocebo is you causing harm from some inert substance. And this is to do with communication. So there are certain sort of words which we use during a normal communication with the patient. So how we talk to the patient and how we deliver the information to the patient can have effects on what they experience. Okay, so all parents want to hear is some reassuring words. So they give you some examples. Okay, we will give painkillers after surgery. Okay, there's something which some of us do say. So when we do this, when we tell this, we basically imply to the parent or the child that there'll be a lot of pain. Okay. So instead of saying we will give painkillers after surgery, you could tell that we will give you medications to keep you as comfortable as possible after surgery. So it's sort of, the words can be used appropriate to whichever language you normally talk to. So try and choose the words which will convey the message, but at the same time not give any negative expectations to the parent or the child. So yeah, so the words which we use can make a difference as to what the parents can perceive. So when you have a child who's crying a lot in the PACU, don't think that pain is the only cause for the crying child. It could be other factors. It could be a full bladder. Okay, it could be that the child wants a cannula removed. It's a new surrounding, new place, new people. The child might want the parent around. So all these have to be looked after. But there is one factor which is very important in children between 2 and 7 years of age, which is called emergence delirium. So this is a phenomenon seen quite commonly after using volatile anesthetics. So the child will thrash around, will not make eye contact, will cry a lot, will move a lot. So so this is called emergence delirium. So all of these are features of emergence delirium. So and the child will not respond to any sort of even if parent is there, they will not be able to console the child. So all these happens within 5-10 minutes of them coming out of anesthesia, but generally they settle automatically within 10-20 minutes. But if it's so bad that the child is trying to sort of injure itself or trying to come off bed, then you might have to do some sedation. So, but pain is one of the causes for emergence delirium, but all emergence delirium is not due to pain. So just be aware of this particular fact, that any crying child, just don't go and give a whack of fentanyl. Okay, you just need some reassurance. Just watch the child. If required, then you might have to sedate either with fentanyl, ketamine, a small dose of propofol, or even clonidine. Again, this is a good website to look at if you want to sort of learn about pediatric pain. There's something you can go through. Again, a lot of guidelines from this particular hospital. People who practice pediatric anesthesia can go through this website. So in summary, pain perceived in early life can have long-lasting changes in the patient, and this can make a significant impact on subsequent surgeries as well. So preterms and neonates are the vulnerable age groups, so you need to be very aggressive with this age group when it comes to pain relief. Second is the pain threshold and the pain tolerance tends to be hugely variable across different age groups and across different patients. So don't have one particular regime for all patients. Okay, so make sure that you see the patient, assess the patient about the risk of pain, and you might have to continue to see them in the post-operative period to see if whatever prescribed is working or not. Pain assessment can be challenging. Take the help of parents and use the pain scores. Yeah, try and use non-pharmacological techniques. Go for multimodal anesthesia where you use different kinds of drugs. Each works for a different mechanism. Preemptive and preventive anesthesia, and opioid sparing anesthesia. And yeah, so one size never fits all. So try to address patients who have a high risk of pain with different techniques. And finally, communication is very, very important when it comes to what you talk to the patient and the child. And this can have an impact onto the outcomes as well. Thanks very much. I'm open for any questions now.
Thank you, sir. Thank you very much for your excellent and elaborate lecture on this pediatric pain management. We have some questions in the chat box.
Sure.
So first question is about multimodal anesthesia in pediatrics. Yeah. So what regimen you will recommend?
Okay, so yeah, so for all patients, I give a paracetamol. If there is no contraindications, NSAIDs. Okay. Third is tramadol. Fourth is I use a block if required. If I can't do a block, I'll do a block. And finally, opioids. So these 5 usually is written. Opioids not always, but the first 3 was normally there. So all patients will get a combination of paracetamol and brufen or diclofenac, and tramadol as a backup plan if it doesn't help. If tramadol also doesn't work, then I go for opioids.
Sir, you talked about the tapentadol. So, do you have any experience of using tapentadol in pediatrics?
Yeah, I've used it for mainly for adolescent patients having scoliosis surgery. So for those patients, it works well, comfortable, but I don't have much experience in using it for smaller children. So the dose is usually getting 50 milligrams capsule. So it's as effective as morphine. And for some reason, the fear for tapentadol is less compared to morphine. And the third thing is, since tapentadol has got a dual mechanism of action, it has got both, it's a strong mu-opioid agonist, and it's also got norepinephrine reuptake inhibition. So it works well for neuropathic pain as well. So that's why it's got advantages over the conventional opioid.
Regarding narcotics in a baby which is less than 1 year, which one is better, morphine or fentanyl?
Okay, so opioid infusions in small children, they say you have to be, both are equally good, but the important caution is they need to be monitored importantly, because the mechanisms to metabolize and excrete these drugs are limited. So among the two, if they have any issues with renal impairment, definitely fentanyl is the choice. Okay, otherwise both are equally good.
So how long that it will take for the diclofenac patch which we applied? So when to apply it, whether preoperatively or how long it will take to act diclofenac patch?
Okay, firstly, I don't have much experience with diclofenac patch. I think it's used more common in adult literature, and I think the minimum patch is only 100 milligrams. So for pediatric age group, I don't think it applies much. But normally it's given once a day, isn't it? It's given as once a day in adult patients. And it takes a few hours to work, 2 to 3 hours to work. But personally, if you ask my opinion, I would prefer the oral or IV diclofenac over patch.
Sir, IV buprenorphine for acute postoperative pain management.
Yeah, I mean, I use more as an adjuvant in regional blocks. So I don't use IV buprenorphine for pain relief, but more as an adjuvant in regional blocks.
Butorphanol, do you use butorphanol? No. Sir, the dexamethasone, what we use in pediatrics, will it give better analgesia, or is it for only antiemetic, or is it?
Which one, sorry?
Dexamethasone. So routinely it is given as an antiemetic in pediatrics. So will it give good analgesia also?
See, I think the only surgery where it's proven to have analgesic effects is in tonsillectomy, but that's been extended to other surgeries as well. So, routine use of dexamethasone in children is more for antiemetic purposes, and for tonsillectomy, probably for pain relief as
well. There are some other questions like, can you show the paracetamol dosage chart again?
Sorry, maximum?
Your slides, sir. Paracetamol dose.
Yeah.
Shall we go for slide share, sir, or shall we take up next question now?
Sorry, sir?
No. Shall we take up the next question and then slide share, or you are ready with the slide share? The paracetamol chart. Somebody is asking for the paracetamol chart again from postgraduate.
Okay, I mean, I'm displaying it actually. So, okay. Should I share screen, is it?
Yes, sir. Yeah. Yeah, thank you, sir. Thank you very much. I think you have taken the distance from that. Sir, do you have any experience of intranasal midazolam producing the anxiolytic, having some effect? Intranasal midazolam. Intranasal midazolam.
Intranasal midazolam. See, earlier we had midazolam syrup actually, but I think nowadays getting midazolam syrup is it's not easy, I think. So we use the IV midazolam and spray it into the nostrils. Yeah, it works. It works quite well actually. It takes 10 to 15 minutes to work for anti-anxiety. But now the common medications which we use nowadays for anti-anxiety is either triclopyr or nasal dexmedetomidine in the dose of 1 to 2 micrograms per kg.
Rajesh, I will add up to that. Nowadays, neonatologists are using nasal midazolam for neonatal patients.
Okay.
They are using that our usual IV midazolam.
IV midazolam, yeah. Okay.
But the Akrula is going to come up with nasal midazolam in the next 2 months. Okay. You go on.
Which one you prefer as adjuvant for caudal anesthesia in daycare surgeries?
Generally, I stick to clonidine. Clonidine, the dose of 1 microgram per kg.
Okay, the rest of the some other questions are also there. Like, is there any precise chart for making it easier for an occasional pediatric anesthesiologist to follow pain management as a protocol? Have you ever come across any protocol? I think you have displayed something from the some other hospital.
No, the Royal Children's Hospital, Melbourne. I think they have a lot of protocols. Actually, it's worthwhile going through that. Some may not be applicable to our country because they may not have the spectrum of drugs which they have. But the basic idea and mechanisms are still the same.
Okay, sir.
I think Dr. Jayanthi is using internationally midazolam. Madam, you can highlight about the international.
Sir, this is commonly used in the ICU when they have patients with seizures. They're not able to control and they don't have an IV access. I've seen them use it. It is available. It's called Midasip. I think one spray gives some 0.5 mg of midazolam. So we have to calculate and give the dose accordingly.
Okay, thank you, ma'am. Rajesh.
Edward, sir, is there any other questions from YouTube or something? Here it is all discussed.
And I have taken all the questions, sir.
Okay, sir. Okay, sir. Thank you, Sanjay sir, for your excellent time with us. Thank you, sir.
Thanks for having me.
Okay, so I'll move ahead with the next session, sir. So the next session we have about perioperative pain management by Dr. Jayanthi. Actually, Dr. Jayanthi is a very senior pediatric anesthesiologist who doesn't need much introduction because he's very much attached to pediatric anesthesia for nearly 90 years. And she is attached with Dr. Ramesh, who is a legend in pediatric anesthesia, working in Kanchi, Kamakoti, CHILDSTrust Hospital, Chennai. And she's very much interested in pediatric airway and pediatric regional anesthesia. And she has been faculties in a lot of national and international conferences and examiner for DM pediatric anesthesia and also IAPA fellowship exam. And right now she is holding the post of treasurer of IAPA for both Tamil Nadu and Puducherry branch. And as far as I remember, a person who had introduced ultrasound for vascular access long back in 2007 for Tamil Nadu is Dr. Jayanthi and her team. We welcome you, ma'am, to deliver the lecture about the perioperative fluid management. Over to you, ma'am.
Thank you very much, sir. Am I audible?
Yes, madam, you are audible.
Yes.
Yeah. So I thank Online Anesthesia, Dr. RAJESH, JEYAPRAKASH for the kind introduction and Dr. Edward Johnson for the invitation. And all, I just heard that the team members of the Online Anesthesia program have been doing yeoman service over the last few months. They have done 38 sessions on every Sunday, covering 2 topics in each session, and that's really truly commendable because we all are aware how much effort it takes to coordinate and to get people together and also to make sure that it reaches the audience. I also thank the sponsors Akrula for providing a platform, and I heard that these sessions are based on Miller's anesthesia textbook. This is truly commendable. I hope the postgraduates are getting their whatever information they need from these lectures, and these are available online as well. Now, over the next half an hour, I'll be doing this topic on perioperative fluid management in children. We'll be discussing various issues of maintenance, replacement, fluids, deficit. They'll all seem a bit confusing. We'll discuss various parts of it. But in the end, I promise you, we'll give you a simple way by which you can give fluids for your patient coming to the operating room. Sorry, 1 minute. So I come from the Kanchi Kamakoti CHILDSTrust Hospital. As Dr. Rajesh was saying, I work with Dr. Ramesh. He's very famous in all our meetings, and we are an exclusive 200-bedded children's hospital. We have cover all surgical specialties. We run a fellowship program in pediatric anesthesia for the past 11 years now. And it's a 1-year program where you'll be able to very comfortably handle children at the end of this period. Now, a little bit of a disclaimer. I will cover as many aspects of the topic as possible, but I'm going to give you some references which will help you to read and increase your knowledge and make your understanding better. We'll try to clarify as many doubts as possible. And pardon for the voice or if I cough in between, because I've not been very well. Now, this topic we'll cover over these headings: a brief introduction, some fasting guidelines. I think somebody was asking about the ERAS protocol, and fasting guidelines have changed in the recent years. I've taken some of these slides from another lecture. We talked about what is new in perioperative fluid management. I think for postgraduates, it's important to get what new information is available. And we look at the assessment and correction of deficit, the intraoperative fluid maintenance, the Holiday and Sega formula, how it was derived and how we have gone from there. What are the replacement fluids we give? What are some of the special situations like newborns where the fluid management is slightly different? A couple of case studies and conclusions. Now, we are all aware that the newborns have a very high total body water percentage of as high as 80%. All of the body is water, and with age, the total body water decreases to about 60%. Initially, within the first week, a large part of the interstitial fluid is lost and comes into the intravascular compartment and is excreted in the form of urine. So the initial first week, the baby loses weight, and because of secretion of various factors, atrial, natriuretic peptide, there's loss of sodium and potassium. So initially, the requirement for fluid is actually less in the newborn period. So first few days of life, you have to be a bit careful how much fluid you give. You generally give a dextrose-based solution. We all know that sodium is predominantly an extracellular cation, and the requirement of sodium is about 2 to 3 milliequivalents per kg. Preterm infants are obligate sodium losers. So only in the preterm and in the infants, you need to give a solution with less sodium. So over the years, our understanding has changed, and initially we used to fear giving sodium solutions for babies or children. So now they say only the initial few weeks of life, as well as up to maybe 1 month of life, you should be careful about the sodium load, and subsequently they are able to handle the sodium load that you give. On the other hand, if you give a hyponatremic solution, there are more problems. While potassium is an intracellular ion and serum sodium levels are poor indicators of total body potassium. But having said that, newborns have high potassium levels per se. They are hyperkalemic. So don't look at a value of 6 or 6.5 and get alarmed. It's quite natural for a newborn to have a higher potassium value. At the same time, you do not give potassium loaded solutions for newborns until they get until there's an adequate urine output. So first day 1 or day 2, they may not require additional potassium at all. Careful potassium administration the first 2 days of life has immature kidneys and there is defective renal function. So renal function is just developing at this point. Now, some of the resources from which I have taken my lecture are the the consensus guidelines which came in 2007 after there was a lot of reports of hyponatremic encephalopathy in children from giving solutions based on holiday against SEGA formula. And then recently in 2015, there was a NICE guidelines. This article, which is available online, is a very extensive and very simple article which gives most of the information from my lecture. Now this chart gives a rough idea of what is the composition of the various body fluids. This helps us to replace the correct solution. You'll find that most of the time, except in the diarrhea, most of the time the sodium and the potassium are as per your ringer lactate or normal saline values. So if you replace isotonic fluids, you'll be replacing most of the body fluids, except for gastric fluids. It's slightly lesser sodium, and of course the anti-diarrheal solution. So the Holiday and SEGA formula was based on this, and they devised a 1/5 normal saline solution with added potassium, trying to correct diarrhea. So that's where the problems came up. We will look at that a little later. So the goal of perioperative fluid therapy itself is to preserve hydration, to compensate for fluid and electrolyte deficits caused by disease or by preoperative fasting, to replace ongoing losses in the intraoperative period like surgical bleeding or insensible losses from respiratory or other causes, and also to continue the same thing in the postoperative period. Now, a few terminology. What is sodium less than 135 is hyponatremia. I think as postgraduates, you'll be familiar with what is osmolarity and tonicity. So osmolarity is number of osmoles per liter of solution. So a solution of 5% dextrose will be hyperosmolar, which has, it is a addition of the various components, the dextrose, the sodium, and the chloride, and you get a number of 286 milliosmoles per liter. But the tonicity is 0 because tonicity is something just compared to that of plasma. So when given intravenously, the dextrose is metabolized, and this 5% dextrose, when it is given intravenously, the dextrose is metabolized and the solution becomes plain water. So when you say tonicity, it is in comparison with the osmolarity of plasma, which is about 300 milliosmoles per liter. So you take any solution, there's always a comparison. Is it isotonic? Is it hypotonic? Is it hypertonic? Because it is important to compare it with that of plasma. Why? The solutions that are isotonic, like sodium chloride or your ringer lactate, which is almost isotonic, when given intravenously, will stay within the intravascular compartment. So you want to give fluids that stay in the intravascular compartment and help to normalize the hemodynamics, or you are trying to give fluids that are similar to plasma or other body fluids. On the other hand, if you give a hypotonic solution, it goes into the goes across the semi-permeable membrane into the intracellular compartment, or it goes into the interstitial fluid and produces edema, either bowel edema or cerebral edema, and that's not what we want. So you will not be giving a solution that is hypotonic. You prefer to give solutions that are isotonic. So you have to use these solutions with caution when you're giving. Give them in limited quantities and give them as required. So this chart shows, it looks a bit baffling, but I can break it down for you. So any solution that has a sodium of, the recommendation is to give solutions with sodium in the range of 131 to 154, which includes NS and RL. So these are both isotonic. They have sodium values like this. They stay within the intravascular compartment, while ringer lactate has a small amount of potassium in it. On the other hand, if you see DNS, which has glucose as well, it's hyperosmolar outside the body, but when given in vivo, it's isotonic because the glucose is metabolized and the sodium and chloride will help to maintain tonicity, and this solution also stays in the intravascular compartment. On the other hand, solutions like 0.45 GNS or the 1/5 normal saline, the isolite P that is was previously recommended, they are hypotonic, they have low sodium values, and they are not recommended. So in the operating room, what is the kind of fluid that you are giving? So you give fluids for correction of the deficit in terms of preoperative fasting, as well as for any resuscitation. Suppose the child is a small baby with a dilated bowel loops coming for a laparotomy, there will be a lot of third spacing, there will be a lot of preoperative loss, the child will be dehydrated. So you need to correct that deficit first. This deficit correction starts in the pre-op and continues into the intraoperative period often. You also give maintenance fluids for the period of the surgery, and you give replacement fluid to replace third space and ongoing surgical losses. You will also replace any bowel outputs that come out. Maintenance and replacement fluids are also continued in the postoperative period as suitable. So what is the role of preoperative fasting time? So the preoperative fasting times used to be much longer previously, and that needed lots of calculation for fluid replacement, and then you calculated 8 hours fasting, divided it and all that. So now the fasting times have become much less, and children are recommended to give clear fluids containing dextrose. They have to be electrolyte and dextrose filled clear fluid is recommended 2 hours before the surgery. So what is clear fluid? It is defined as either water, fruit punch, fruit juice without pulp, coffee or tea without milk, anything through which you can see through, or ice, lollies or popsicles. So this makes the children more comfortable. They are less dehydrated. They do not go into hypoglycemia. The initial induction with propofol or any drugs or sevoflurane, you don't get hypotension as well. So all these reasons, and the fact that their MRI has shown that the fluid from the stomach empties within about 15 to 30 minutes. So all these factors have led the international guideline committees to change the fasting guidelines to a 6-4-2 rule, where 6 hours for solids, 4 hours for formula and blessed milk, and 2 hours for clear liquids. So we also encourage resuming feeding clear liquids early, as soon as possible after the procedure. Usually it is within 1 to 2 hours, unless if there are any surgical reasons to postpone. Now the surgeons are pro feeding as well. So generally most children get fed within an hour. And our general rule is, if the child is fully awake, you can feed the child. So no need, so the current guidelines recommend there's no need for giving IV fluids for very short procedures if the fasting period is short and the resumption of orals is early with an IV access in place. Suppose you have a child coming with a 2-hour fasting period, coming for an incision and drainage, or for a short orthopedic procedure lasting about 15 to 20 minutes or half an hour, then you can get away if they are without giving IV fluids, and if you can resume fast feeding early after the procedure, provided there's an IV access in place. So going further from the 6-4-2 rule, there are papers talking about 6-4-0, which is actually 1 hour before procedure, because they call for the child and it takes about half an hour to 45 minutes for the child to come into the operating room itself. So is 1 hour the answer? So a lot of societies have also recommended 1 hour fasting. This is for clear liquids. But in the Indian scenario, even 2 hours, it's difficult to make the parents understand that what kind of fluid is allowed to give. We have had occasions when parents have fed the child milk and we've had to postpone. They are anxious about the whole procedure itself, and sometimes they don't understand. So let's take the child coming into the operating room first. So you have a child who's posted for a laparotomy, and the first thing that you need to do is estimate the amount of dehydration. The child has been admitted to the emergency room maybe, and the surgeon has posted for a procedure. You have to estimate the dehydration and start the correction. Some of the factors that can give you an idea about what is the level of dehydration. Based on the level of dehydration, for every 1% of dehydration, 10 ml per kg is the recommended IV fluid, and this fluid will be normal saline or ringer lactate. So some criteria are looking at the pulse, respiration. Generally, the demeanor of the child. Is the child irritable? Are the mucous membranes moist? What is the urine output? So some capillary refill time. So some factors that occur early are, you get a tachycardia early, but the BP drops quite late. And the capillary refill time is an excellent indicator. If you keep using it, you will very quickly be able to see, either give pressure in the palm of the hand or at the fingertip, and you will see the blanching being, there'll be a flush within 2 to 3 seconds. So if it's more than 3 seconds, it is prolonged. Based on this, what is the estimation of deficit? So if the child is severe deficit, the deficit can be as high as 100 ml per kg. So that's how much you have to replace. So by which time the pulse is feeble, the extremities are cold, the eyes are sunken, fontanelle is sunken, and the BP would have fallen. So here are some red flags that indicate that the child is going in for hypovolemic shock. If the child coming into the operation theater, first thing you see is the child crying and is the child alert? So if they are quiet, it's not a good thing for you. You might find it easier to induce the child, but that just means that the child is going in for dehydration. On the other hand, if the child is bright and awake, you can ask the parents, has some resuscitation happened? Is there a urine output? If they say there is a urine output, that means your resuscitation is adequate. If the child is tachypneic, tachycardic, there's reduced skin turgor shown by what's called the pinch test. So you pinch the skin and the skin does not go back to its normal position. That's called a positive test, which means there is significant dehydration. Hypotension, prolonged capillary refill time, and weak pulses are all signs of hypovolemic shock. Here is a child who's actually posted for a cleft lip repair, but unfortunately came in with diarrhea. You can see the eyes are sunken, respiration is slow, and the child was severely dehydrated in shock. With 2 boluses, there was a capillary refill time was prolonged, tachycardic, hypotensive, pale, mottled skin. Resuscitate with 10 to 20 ml of ringalactate or normal saline over 10 to 20 minutes and reassess after each bolus. You can give up to 3 boluses. As you can assess with heart rate, sensorium, capillary refill time, and the blood pressure. Now, newer modalities for assessment would be the transthoracic echo, the diameter of the IVC on ultrasound, and these will help you to judge. Generally, with the heart rate quickly comes down the moment you give a bolus. Even intraoperatively, if you're not sure if it's pain or dehydration or blood loss is the cause, a bolus and you see a change, slight drop in heart rate, you'll know that it's because of the dehydration or you're behind fluids, and that's the reason for the tachycardia. So this is a child after the resuscitation. So just a quick few numbers for you to know as postgraduates. So minimum systolic BP is 70 plus 2 into age in years. So if the surgeon or you want to know the blood pressure, this is a quick formula that you can have. Now, deficit correction continues. So initially you give 20 ml over 20 minutes, over 10 minutes to normalize extracellular fluid volume in case of circulatory instability or blood loss. After 2-3 boluses, you reassess each time and think of other causes. Colloids, when large volumes of crystalloids have already been given, and you think of giving blood or going ahead with other, think of other causes. Now, generally, if the fasting period is long, you replace with the isotonic fluid. All of us are familiar with the Holiday and Sega formula, the 4-2-1 rule. I'll be explaining how it was derived in the next few slides. You replace, you calculate the number of hours, how many ml per hour, and then you give half in the first hour and the remaining 1/4 over the next 2 hours. This is one older Furman formula. Now, coming to the maintenance fluids, as early as this was the Holiday and Sega formula that was described, and this is still being followed by most anesthetists to calculate the hourly requirement of fluids in children. It was described in 1957 based on the composition of human and cow's milk and the caloric requirement and expenditure, caloric requirement and water expenditure. They found that for each calorie metabolized, 0.2 ml of water is produced and 1.2 ml of water is consumed. So energy expenditure is equal to water requirement. So they said water usage and energy expenditure, they equated, and an active child who needs about 100 to 130 kilocalories per kg per day requires the same amount of fluid, and this was reduced in little older children. Sodium and potassium requirements based on cows and human milk were 2 and 3 milliequivalents per kg per day. And we got the 4-2-1 rule when you divided this by 24 for getting hourly requirement. Based on the composition of human and cow's milk, they devised the 1/5 normal saline with dextrose and with added potassium. This was the isolate P solution, and in the UK it was 1/4 normal saline with dextrose. So here you have the 4-2-1 rule, where less than 10 kilos, all of us are aware, 4 ml per kg, and subsequently add 2 ml per kg and 1 ml per kg. So you calculate the hourly requirement based on this and divide it by half. You give half in the first hour of surgery and 1/4 over the next 2 hours. Now, though this was started, this Holiday and Sega formula was devised as early as 1957. Now 50 years have passed, and in the late 90s and early 2000, they found several children in the US, I think about 15,000 deaths in children because of hyponatremic encephalopathy. They found that people were giving this hyponatremic hypotonic solution for long periods of time. So Holiday and Saga devised it so that it's an anti-diarrheal solution. So people started giving it in the operating room and in the post-op and everywhere because it's a very simple formula and it was recommended. So they found that the sodium content of this solution that was recommended is low. So if you still, I'm not sure how many of you still use isolate P. So if you still use isolate P, it is going to get you into all sorts of trouble because it's a hypotonic solution with 5% dextrose. And the problem with it is it promotes the incidence of hyponatremic encephalopathy, which can lead to cerebral edema and convulsions, especially in a situation where there is ADH excess. So the volume recommended is also higher because in surgical patients, there is ADH excess, and this contributes to volume retention. So volume is higher, sodium content is lower, and the dextrose is really not so necessary because several studies have shown that stress of surgery mounts a response where there is hyperglycemia. So this dextrose issue came up because they found newborns with hypoglycemia. There were MRI changes, and this led to convulsions and long-term complications. So they extrapolated that data and said all children need dextrose. But then several studies by Wellborn in the 80s have found that dextrose is really not required because, one, the surgical stress mounts a stress response, and they looked at several children and all had higher dextrose levels at surgery. And now with the revised fasting times, where you have a 2-hour fasting window and the child is already fed the glucose drink 2 hours before with electrolytes in it. So you really don't need so much dextrose. So the dextrose, on the other hand, is not innocuous. It produces dehydration and osmotic diuresis. So it is highly recommended to give isotonic solutions like RL or NS, which have a good amount of sodium with a smaller concentration of dextrose, maybe a 1 or a 2.5% dextrose solution, so that you don't have hypoglycemia if you're worried about that. And at the same time, it's not hyperglycemia producing dehydration and osmotic diuresis. So what maintenance fluids do we give? Do we give RL? It's slightly hypotonic when compared to plasma. Plasma has a 300 millimoles per liter, and this is only 276. On the other hand, normal saline has a sodium is little higher and can produce hyperchloremic acidosis with large volumes. So it is not, they are saying it's not recommended, but these are all only for very large volumes that are given, and for the periods of time that we give in the operating room, these two are fine. Plasma light, some people recommend for major procedures, but it's generally not so freely available, at least in most hospitals. So we still stick with ringalactate or normal saline with added dextrose. So you can give straight away 10 ml per kg per hour for the first hour for short procedures, taking into account pre-op fasting and post-operative time to resume feeds. So a balanced electrolyte salt solution with 1% dextrose is what is ideal. So how do you make that? You add 20 ml of 25% dextrose to a 480 ml of RL or NS and you get a 1% dextrose solution. So when do you need to give dextrose? Especially you have to make sure. So if you get a patient for a circumcision, you can just put who's fasted for 2 or 3 hours. You just start ringalactate or normal saline at 10 ml per kg for maybe the circumcision takes half an hour, maybe takes 1 hour. So at the end of it, you give 10 ml per kg and the child is shifted to the recovery. If you do check the glucose, you will find that there is adequate dextrose. We've done a study in our hospital with one of the surgical postgraduates where they just took random sugar samples at induction, at recovery for all daycare procedures and found very high sugar values, even though the children were fasted for 3 to 4 hours. So you really don't need to give dextrose. You need to give dextrose only for newborns, preterms, and those on dextrose infusion. Preterms and newborns especially. So generally what happens is when you have a newborn or a preterm, they come from the newborn ward on a dextrose infusion. You just continue that as a maintenance fluid and give replacement fluid and other things with other isotonic fluids like ringalactate or dextrose. So this goes on as a background infusion. You could otherwise give 1 or 2.5% solution. And if you're not sure about whether there's hypoglycemia, you can monitor the glucose for longer procedures. Check glucose and give where necessary. Hypoglycemia is a glucose value of less than 40 milligrams per deciliter in newborn over 48 hours and less than 60 milligrams per deciliter in older infants and children with symptoms. Treat with 10% dextrose at 2 ml per kg and continue the infusion of dextrose at 5 to 6 milligram per kg per minute. So this is what you need to do if you do find a sugar value that's less than 60 milligrams per deciliter. So when do you suspect hypoglycemia? When the child is not waking up at the end of the anesthetic, you've given enough sugar, you have not given enough sugar, or inadvertently in the recovery or in the post-operative period, the child has sometimes they have a seizure or not responding or not doing very well. Now the guidelines for maintenance fluids now at the end of this would be isotonic ringalactate or normal saline based on the 4-2-1 rule, dextrose only in specific instances, and monitor blood glucose intraoperatively when necessary. Usually if the duration of the procedure is more than 3 hours, you definitely need to give dextrose. Replacement fluid. So the replacement fluid that we are giving is going to replace ongoing losses, renal, cutaneous, and blood loss. Replacement solution is again same, your isotonic ringalactate or normal saline at 10 to 20 ml per kg over 10 minutes when there's acute loss. More than 40 to 60 ml of crystalloids, consider colloids or blood. Generally in children, we'll be seeing the colloids. It's not very much recommended. As far as possible, we try to give crystalloids, and then when there's blood loss, we give blood. But of course, there is a small window or room for colloids. We'll talk about it. Replace blood with a PRBC transfusion when the loss exceeds the maximum allowable blood loss. Does third space exist? So there's a lot of adult studies. So much of the literature in children comes from adult work. So the adult studies are saying there's no third space does not exist, but in children there's no conclusive evidence, and they found that a very restrictive policy led to a lot of problems as seen in this article. So we continue to replace for third space loss, and in a child coming for a necrotizing enterocolitis or major bowel surgery in a preterm or a newborn, the third space loss can be so significant, and your replacement may have to be at least up to 50 ml per kg. So that's the amount of third spacing, and it's important that you're aware of it and do replace third space. So for third space loss, for superficial procedures, we do 1 to 2 ml per kg, 4 to 7 ml per kg per hour for a thoracotomy, and more for an abdominal procedures. So simply follow the heart rate, the blood pressure, and if any message from today's lecture, it would be follow the capillary refill time. And sometimes even the EtCO2 is a good indicator of what is the perfusion. So if you're looking at an initial EtCO2, sometimes all numbers are hazy, the heart rate is always high, you don't know what to do, you're not sure if the child is getting enough fluid. The surgeon is operating, but you seem to be giving a lot of fluid and there's no response. The blood pressure is just borderline. So that's when you look at the EtCO2. If the starting EtCO2 was 30 and it's dropped to about 22, then you know that you are actually behind fluids. Maybe you need to give colloid, maybe you need to give blood to bring things, improve things. So what is the consensus on colloids? So the recent articles have gone through in detail, and we are all aware that you have the naturally occurring colloid albumin, which is actually the gold standard, while the artificial colloids are the hydroxyethyl starches and the gelatins. Now this HES 130, which has a high molecular weight, is supposed to be better than the others because it produces less chances of anaphylaxis, renal issues, and coagulation problems. But all colloids, if you stick to a dose of about 10 to 15 ml per kg and a maximum dose of 50 ml per kg, the chances of problems are less. So keep the problems at the back of your mind and do not recommend giving colloids in situations where there are leaky capillaries like sepsis or traumatic brain injury. And albumin is the preferred colloid in newborns. So coming to blood transfusion, this is a very debated topic. It varies from center to center, depending on the situation. Each anesthetist have their criteria, but generally 10% of blood loss is what you attempt to immediately replace. You will replace initially with crystalloids, and beyond about 20, maybe 30 ml per kg of crystalloid, you switch to blood. But having said that, the maximum allowable blood loss is an estimated blood volume into the initial hematocrit minus acceptable hematocrit by the initial hematocrit. And the transfusion trigger is supposed to be about 7 grams per deciliter in children. In ongoing loss, we tend to accept a higher, go for a higher transfusion trigger of maybe about 8 grams. So in our babies, when the starting HB is about 10 grams and you have seen some blood loss, you quickly start replacing with blood. You will, in children, the total blood volume is at about 70 to 80 ml per kg in 10 kg child will be about 700 mils, and after about 100 or 200 mils, it's time to replace. So by the time you get the blood, you would have reached these numbers. So the volume of packed cell, just a quick way to judge is weight in kg into the desired increment in hemoglobin into 5. That will give you how much volume of packed cells you need to replace. So looking at the blood volume in neonates, it's about higher, 85 to 90 ml per kg. In infants, it's about 75 to 80. In older children, it comes lower, and where you reach the adult values of 65 to 70 ml per kg. So certain special situations that I'd like to touch, especially neurosurgery. A lot of you may be doing the small babies coming for neurosurgical procedures. The common maintenance and replacement fluid that we use is normal saline. It is hyperosmolar and prevents cerebral edema. Oral can be given, but there is some thought that it may be hypoosmolar and can precipitate some cerebral edema. Glucose containing fluids we do not use except in special situations like newborns, because hyperglycemia worsens reperfusion injury. And premature infants and neonates, of course, fluids contain glucose. You could safely give a 1 or a 2.5% fluid and get away with it. And blood transfusion is guided by hematocrit and the degree of loss. Just briefly touching on newborns, because sometimes you have a question on a newborn coming for a laparotomy. Newborns are hyperkalemic, hypochloremic, hypocalcemic, and hypoglycemic by nature. So if you see higher potassium values or chloride values, then that's how they are. So you need to correct deficit with isotonic fluids like normal saline. Albumin is the recommended colloid in newborns, whereas for replacement crystalloid, it's usually normal saline. Like I said, maybe in the first month of life, you would give half normal saline, but after that, the newborn neonatologists recommend normal saline as a replacement fluid. But very quickly, you'll reach your volumes, and often we end up giving either FFP as a colloid, or we give, suppose you have a good hemoglobin, there's not much loss, the abdomen is open, the surgeon is doing a laparotomy, you've given your requisite amount of crystalloid, and you still need that little bit colloid of some sort. then it's nice to give some FFP if it's available, because that also makes up for any sepsis, there's any coagulation problems. So all these will be taken care of by the FFP. So replace the blood loss initially with a 2:1 crystalloid, 5% albumin, and then blood as required. So this chart gives you an idea about the fluid requirements. So initial day of life, the fluid requirements are less because they are trying to lose fluid and you don't want to overload them. And subsequently, the fluid requirement reaches normal newborn values. So we have a child here who's a 3.2 kg child at 32 days of age with non-bilious vomiting for 1 week. Child appears a little dull. The heart rate is about 148 per minute, respiratory rate 28 per minute, urine output is there. And the electrolytes, these are the electrolytes. So you can see that the sodium is low and the potassium is probably indicating dehydration. Chloride is low, hypochloremic, hypokalemic alkalosis, and the creatinine is not too bad actually, and the hematocrit is 38. So this child was initially corrected with a 0.9 GNS, which will correct the sodium with 2 millicolons per kg potassium at, so they are giving less potassium at 150 ml per kg per day, and the potassium is added if there is urine output. So that's the general dictum. And in children, you can give maybe for 3 to 4 hours and reassess. So on reassessment of the fluid bolus, they found after a few hours, they found that the sodium is overcorrected, the chloride is corrected as well, and the potassium is on the higher side. So they have readjusted the fluid after this. So you got a good urine output 2.2 ml per kg per day, and the child was initially looking a bit dull, but when the child came for the procedure was really active and busy. Now subsequent correction was with 0.45 GNS without added potassium, and pyloromyotomy was done. So this child will go back to the ward, and generally our dictum is pyloromyotomy is not a emergency surgery. It needs good correction before taking up for procedure. For every week of vomiting, the child is corrected for at least 1 day. That's a general rule of thumb. So once the electrolytes are corrected, then it's ideal to take up for procedure. So even having said that, even though you have corrected the electrolytes, they're still a bit hyponatremic, and they tend to take a long time to wake up. So the relaxant effects may last for much longer, and you have to be very cautious. A good regional with very minimum IV drugs with just some sevoflurane, intubation with a small dose, maybe half dose of atracurium, and a good caudal or a local block will take care of the anesthetic. And then the child has to be fully awake when extubated, because there are reports of children going back into apneic spells in the post-operative period, and we don't want that. So continue the 0.45 GNS for the procedure and post-op, and check the electrolytes post-op. Now this is another child. This is a simple procedure child coming 10 kilos for a left open occupopexy, has been fasted for 2 hours. The parents understood what you meant by clear fluids. So nowadays, most parents understand if you tell them ORS. So ORS apple is a very common thing that they understand, and that is something safe. It has electrolytes, it has glucose. So there was a question about ERAS and asking if you can give a dextrose containing fluid. So the recommendation for preoperative oral fluid 2 hours before or 1 hour before is actually dextrose and electrolytes should be present. So this ORS apple is great, and a lot of children like it. So many people recommend the tender coconut water, but the children don't understand what that is, and they probably never had it. The other thing we recommend is Appy, which is a fruit drink, or any other fruit drink, which is clear. So what fluid would you give? This child can have 10 ml per kg of ringalactate over 1 hour and feed subsequently. As Dr. Sanjay was saying, we always combine a regional block and give dexamethasone IV, so that it acts as antiemetic and also analgesic, and that prevents any nausea from the occupopexy procedure. This is a newborn coming for a laparotomy for a jejunal atresia. The child is about 3 kg, still within the 1 month period. Heart rate is a bit high. The blood pressure is just about okay, and electrolytes are, potassium is a little low, chloride is low as well. So there is not much urine output. So you continue the 10% dextrose intraoperatively at 12 ml per kg, which is 12 ml per hour, sorry. This is the 4 ml per kg per hour based on the Holiday and Sega formula. And another IV access you can give bringalactate. First you give a 30 ml bolus, that is 10 ml per kg over 10 minutes, and wait, and then you'll find that the heart rate drops a little bit. Then you give another bolus, and subsequently, once there is some sign of urine output, you can proceed with the surgery itself. So it's worthwhile waiting a little while, resuscitating your patient, and then proceeding, because this child was intubated in the newborn unit and they had already started resuscitation but was severely dehydrated. You could also at this point ask for some FFP or colloid, or albumin is available. I think albumin is now available and it costs about 1,000 to 2,000 rupees. Not too bad. Initially, in between, it was very expensive. So albumin is the recommended colloid in this scenario in newborns. So you can give albumin or FFP, and then once a procedure starts, based on how they are proceeding, whether there's going to be a resection, you can give blood. So most of the time here you can see that we are giving a tap block because probably the child was septic, the platelet counts were low, and it was not recommended to give a caudal block. Otherwise, a caudal block is an excellent and important armamentarium for all procedures in the abdominal procedures, and that takes care of most of the pain. Dr. Sanjay gave an extensive and elaborate account of the pain relief mechanisms, and this is the newborns, and I think most children are a group where a good regional block is the beginning for all pain relief, and he very clearly indicated how about the drugs and various things as well. So the next two slides are important. It just give you a summary of all that I've been talking. So any patient, perioperative intravenous fluid therapy, rule of 10. Just remember the rule of 10. You can give what you give as maintenance. You give a balanced salt solution with dextrose. So you add 20 ml of 25% dextrose to an RL, you get a 1% solution. You give that at 10 ml per kg per hour. You can't go wrong. Next is what? Replacement therapy. Suppose you have to give a bolus if there is hypotension. What do? You give 10 to 20 ml per kg. If you're giving any colloids, what do? You give 5 to 10 ml per kg. And the maximum of about, generally at about between 10 to 15, you're fine, and maximum is 50 ml per kg. The transfusion again is about 10 ml per kg. So if you just remember this, you will be safe. And generally, children are quite forgiving. You give a little extra, they do have good enuresis as long as urine output is good. But having said that, it's ideal to use a burette set for any child less than 10 kilos. And infusion pumps are fine, but infusion pumps have a lot of problems. So you should make sure they don't extravasate, because they tend to push the fluid. So proposal for perioperative IV fluid in children: preoperatively, keep fasting times short, clear fluids 2 hours pre-op. Minor procedures, give a background infusion of 10 ml per kg of our balanced salt solution with glucose. Intermediate procedures, adjust the solution to the actual requirement. So you give the same thing over that 1 or 2 hours, but you make sure there is some added dextrose, and based on how much loss is there, you supplement with extra isotonic fluid like RL or NS. Colloids if the additional balanced salt solution is required, and blood if necessary. For major procedures, blood and blood products. So you will find that calculating the blood volume, 10% of the blood volume is what you target to ask for blood. And beyond that, very quickly in major neurosurgical procedures, you will find that the blood loss quickly reaches the massive transfusion levels. So you have to be cautious in following the blood loss and replacing with blood. So this easily summarizes what is the thought process in a pediatric anesthetist. It is important for them to design a system of care that can develop perioperative fluid recommendations in the local environment, and to adjust the administration of fluids to the child based on guidelines, factoring individual circumstances. This is just to say that some solution may be available in the West. So there is something called bionic in the Europe and other countries, which is a balanced salt solution with dextrose, but that's not available in India. So we have to make our own, or sometimes we supplement with 0.45 GNS in smaller children. So you have to adjust according to your criteria. And we might say 2 hours, 1 hour for clear fluids in some other country, but in India, the parents don't understand. So you're better off giving them advice 2 hours and then telling them what fluid exactly to give and telling them what solutions to give. Because socioeconomic conditions vary across the world, the guidelines and practice will vary, and consensus will likely remain local for the foreseeable future. So these are some articles from our own colleagues which are easily available and excellent reviews. So we have a pediatric anesthesia meeting in Coimbatore coming in February, and I would recommend all of you to attend the meeting to get more information and to learn more about pediatric anesthesia. Thank you. These are some of my references other than the ones I already showed.
Jayaprakasha sir. So thank you, madam, for a wonderful lecture. I thank you once again for, even you are suffering from URI, you take all the that shows your commitment to teaching. Thank you.
Problem.
Jayaprakasha sir.
Thank you, ma'am. Thank you for the excellent elaborate lecture. We have some questions on board, madam.
Yes.
First to start with, like post-operative feeding. Is there any recommendation to how to start with and what type of fluid first? Then.
So post-operative, usually we start with water if the child is old enough. Newborns, they don't give water. So newborns and smaller babies only breastfed. We'll give breastfeed once the baby opens eyes and is awake and crying, can be fed. So basically, it also depends on what drugs you use intra-op. We generally don't use much narcotics. Our technique is a lot of regional, a little bit ketamine, and some narcotic if necessary, very small quantity, not the higher doses. So we'll probably use a fentanyl, which is short acting. So in that kind of situation, if you're aware that your child is well to take feeds, is fully awake and crying, then a mother can feed even at 2 hours. So 2 hours is a safe time, but a lot of them, by the time you give the child to the recovery, they're just screaming and shouting. So the only thing that can calm them is they're quite awake, they have airway control, they can swallow, so they're fine. And they're not going to vomit because none of the drugs that you've given are going to stimulate vomiting. So anyway, the IV is there in place as well.
No, this is a question from Edward, sir. As the formula, that holiday formula for restricted or liberal fluid therapy in pediatrics?
I think it will come under, good question, I think I must find out. It's probably restricted. That's why you must interact with PGs. They're asking thought-provoking questions. Anyway, good. Transmission.
Holiday that formula is it's a controversial formula.
Yes, it's controversial.
Because
it's now they have
liberal fluid therapy. So in some patients it is acts as a liberal fluid therapy.
So in the post-operative period, it will become liberal because we want to reduce it to 80% in the post-op. But otherwise, if you take it as a general rule, it should be restricted only.
Okay.
Is there any?
Yes, sir.
Yes, I want to tell something.
No, sir. The transfusion trigger in preterm and newborn is slightly higher. So preterm generally 12 grams and 10 grams. 12 grams is with oxygen, 10 grams is without. But having said that, a lot of preterms we want 12 grams because they're more prone for apnea, and anemia is one of the important contributors for post-operative apnea.
Is there any prepared isotonic solution with 1 to 2% of dextrose available in the market commercially?
It's not available, sir.
Is FFP is allowed to use like colloid in pediatrics?
Yeah, that's a controversial topic, which in every pediatric meeting we discuss. But having said that, I have seen some of the Western, I've asked the same question to some of our Western colleagues, and they have said that in newborns, you can take it as it's a kind of a treatment modality, because that child is septic, is already having a bowel procedure, is losing blood. So you're giving a colloid, and that situation giving FFP is fine. But if you look at the infection risk and the risk of giving a blood product, then it should not be given. If albumin is given, it is recommended, is available, it's recommended to give albumin over FFP.
So they've taken the infection risk into consideration. We have to avoid.
So if they ask in an exam, you cannot say I give FFP.
The preoperative clear fluid, how much volume is it?
Preoperative clear fluid is, I think it's about 5 ml per kg, if I remember right. Yeah, 5 ml per 5 to 10 ml per kg is what is recommended. I can confirm that and get back to you and put it on the group, sir.
As you say that IV fluids can be skipped at all for a minor.
Sir, I didn't get you. Can IV fluids?
Can be skipped in minor surgeries.
Yes. So, couple of things. One is you must make sure that the child feeds immediately post-op. So let's say you have a procedure, they have done an IND for a child, and the child was fasting only for 2 hours before. So you think, okay, no IV fluids. I've taken the child to the recovery, and you tell the sister, feed the child. The child is crying, mother doesn't feed, and it goes on like that for some time. So that is the kind of thing that you need to make sure the mother feeds the child and the child gets the requisite amount of fluid. And sometimes they're so restless from your sevoflurane or something that takes some time, but that's okay. As long as they feed within a reasonable time, that's okay. Otherwise, if you're not confident that they will be able to feed, or there have been occasions where there was a patient who went home because the child did not feed very well and they didn't feed for a long time. Then the child started vomiting more and more and was going into a hyponatremia kind of situation. So they came back. So that kind of thing should be avoided. If you have the support that you can feed the child immediately, then no need for fluids. Generally, in a hospital setup, that should be okay. It's not too difficult.
Role of IVC diameter measurement and the fluid resuscitation pediatrics.
So that I think I'll ask all the adult anesthetists. we do it. I put that in only because that's something current. But we have seen the IVC diameter, and it's more like, what shall I say? Like we want to do ultrasound and learn more, and in that context. In an acute setting, I'm not sure, unless you're a true expert. And I think a lot of the ICU people use it more than the anesthetists, unless there are a lot of seniors here who use the ultrasound a lot. It can be used. We have just seen it as just so that we also know what it is in that context, but not really. There was some resuscitation when we were giving a lot of fluid and we're not seeing a response. So we got the cardiologist to do an echo to see what is wrong with the heart. Why isn't there an output, or why is the child recovering? So that time, any assessment of the IVC diameter, we found actually, in spite of all the fluid we were given, it was really not, the IVC was not large enough for that age of the child. One problem with the IVC diameters, there are no guidelines for age of child, only compressibility you can see. So based on the compressibility and the change with respiration, you'll have to make a judgment. I think Sanjay might know more.
That's a question related to the volume of the caudal block. Is that 1.25 ml per kg is adequate for pyromyotomy procedure?
Yes, 1.2. Yes, that's fine. So you can give, now we give even rector sheath block, or the local itself is adequate. one advantage of caudal is that when the surgeon operates, the bowel is not popping out, or it's quiet. But these small babies with pyloric, they are quite dehydrated, and how much ever rehydration happens, they don't need too much of relaxant and things. So in that way, this particular baby, that photo, the child looks very active. So if you don't give enough, the bowel will keep coming out when the surgeon is operating. So in that context, caudal is an excellent block, and for post-op as well. You can get away with giving much less anesthetic.
Should we go for irradiated blood for preoperative if the hemoglobin is low in preterm or neonate?
So now that's what they are recommending, sir. Preterms and neonates, they are giving irradiated blood. And single pack from single donor packs they're giving. So one same child will get only from one donor, so that you don't have too much infection risk exposure.
So to make it summarize, is 10 ml per kg isotonic solution is sufficient for maintenance rather than the standard 4-to-1 rule?
Sir, rather than?
The standard 4-to-1 rule. 4-to-1 rule.
Yes, 10 ml per kg is adequate. So it will cover the pre-op, post-op, everything. You just give. That's up to a couple of hours. You can give that. More than 2 to 3 hours, then you have to calculate every hour what's happening in the surgery, whether you need more replacement, all that you can.
Sanjay sir, are you there? There's a question to Sanjay Prabhu sir.
I think he is not there.
There was a question like what medication can be given for emergency delirium in pediatrics?
So emergence, generally we are giving either propofol or dexmedetomidine, a small dose ketamine maybe. So all these drugs can themselves produce some emergence. So you give dexmed, seems to be an excellent drug. If you are anticipating emergence, like in some children who are already hyper, or you've used a lot of sevoflurane, then you might as well give the dexmed before. So they wake up much more quiet, like the tonsil. Tonsils, the chances of that is much higher. So you give dexmed in the beginning of the procedure, small dose, and they wake up quiet.
Yes, Rajesh sir, evidence-based medicine, they advise dexmedetomidine is the best trick for the emergency.
Up to what age group that 10 ml per kg per hour formula can be followed?
You mean the lower limit, or?
Both upper and lower limits. 10 ml per kg.
Upper limit is for, like, we use even in adolescent, older children, it's not a problem. Lower limit is, I think, see, the thing is when they come for surgery, they are not fully hydrated anyway. So you can start off anything 10 ml per kg, you can start off, even the newborn. It's not a problem. And then you reassess and decide. It's always a question of reassessment. You just don't, initially, if you give that, you're not going to go into pulmonary edema and have any problems with that. So there is a caveat for this 10 ml per kg rule, where they are saying use with caution in children with cardiac or renal disease. So anyway, those children, you're going to be cautious. So all others you can give. It's not a problem.
Regarding the transfusion in pediatric age group, particularly in the newborn,
yes,
is it
sir.
mandatory to go for cross-matching? Because can we give any other blood group, because there won't be any antibodies in the blood?
We always cross-match and give. Yes.
This is a question from Parthasarathi sir. Is continued monitoring of hand-on pulse for volume status?
No, it's never gone, sir. So always, now we have ETCO2 as one. It's become like hand-on pulse, or instead of your precordial state, you have ETCO2. I would only say that, but nothing beats hand-on pulse. Even under the drapes, you can feel in small babies less than 6 months, you feel the brachial artery on the medial side of the arm. That's better, or you can feel the carotid, of course. but nothing beats that in assessment of volume, in what's happening to the child. Is everything okay? There's no monitor. Lot of situations the monitor goes off or you're shifting the child. Nothing like hand on pulse. And I'm glad sir brought that up. Precordial stent, unfortunately, we are not using. We have ETCO2 instead of that. I don't know, like others are using ETCO2, I'm sorry, precordial stent, I'm not sure. Sir, are you using?
In our days, precordial stent is mandatory for pediatric patients.
Okay, now?
Now also I advise, because the patient is fully draped.
Okay.
And we cannot.
I also would like to add, ma'am, there are times when the monitor doesn't function.
Yes.
There are times when the ECG doesn't come. In that moment, at least if we fix up the precordial stent, at that moment at least we can.
Excellent. I'm glad.
Till now I
it's
do
still being
do it for small kids and for major procedures.
Excellent.
Very
good.
small kids.
It's our postgraduate teaching.
Excellent. I'm glad it's still being used.
Yes.
We all grew up with the precordial stent, but now.
Yeah, ma'am. And I grew up with no monitors actually. It was just hand on pulse and with a precordial stent. So
Very good.
thank you, ma'am.
I think we have taken up almost all the questions, sir. Any other questions remaining, sir? Edward, sir?
No, sir. All the questions were taken from the YouTube. So thank you very much, madam. Thank you.
From our side, before conclude, from our side, we can wish all the postgraduates and people here world, because this week is going to be celebrated World Anesthesia Day. So we wish them good celebration in the department for the World Anesthesia Day. And thank you for both the speakers who had spent their eminent time with us. And thank you, Edward, sir, for giving us this opportunity. Thank you. Thank you.
Thank you, sir.
Thank you for the both speakers for excellent coverage of the theory part and as well as the practical tips you have given to the consultant. Thank you once again, Sanjay Professor and Jayanthi Madam.
Thank you.
I thank Rajesh sir for wonderful coordination of this program. And I also thank the sponsor Akrula and A1 Logics host and also Anaesthesia TV. Thank you. Thank you once again. We will meet next week with an interesting topic.
Thank you, sir.
Thank you.